Welcome to Moving Toward a Targeted Approach for Nasal Polyps, presented by the Postgraduate Institute for Medicine at Immunology Live, in collaboration with the Asthma and Allergy Foundation of America. My name is Dr. John Basso. I'm an allergist and immunologist and clinical professor at the Division of Rhinology, Department of Otorhinolaryngology, Head and Neck Surgery, University of Pennsylvania, Perelman School of Medicine. Activities on Immunology Live are interactive, allowing us to take your questions in real time throughout the presentation. We encourage you to enter your questions at any time in the box below. I'd now like to introduce my co-presenters, Dr. Zachary Soler, Associate Professor of Otolaryngology, Head and Neck Surgery at the Medical University of South Carolina, and Sanaz Eftekhari, Vice President, Corporate Affairs and Research of the Asthma and Allergy Foundation of America. Thank you both for joining me today. Let's get started. Here are our disclosures. Here are the learning objectives. To summarize disease burden experienced by patients with nasal polyps, to list the limitations of traditional interventions for nasal polyps, including oral or nasal steroids, antibiotics, and surgery, to explain rationale for locally and immunologically targeted approaches to nasal polyp management, and to summarize the efficacy and safety of new and emerging therapies with new mechanisms of action and or modes of administration for patients with nasal polyps. Next, I'm going to transition to Dr. Soler, who will discuss the epidemiology and associations of nasal polyps.
Thanks, John. So I know we have a broad audience today, so let's just start with some basics. First is, what are nasal polyps? Well, nasal polyps really represent a subset of chronic sinusitis, and they represent chronic inflammation of the lining of the nose and sinuses that swells and forms these grape-like prominences. And you can see the picture here, they come in different shapes and sizes and consistencies, and a lot of times people like to think of them like a grape if you peel the skin off and you looked on the inside. We're going to talk a lot more about pathophysiology a little bit later today and how they develop. But the patients with polyps oftentimes are associated with a number of different comorbidities, including allergy, asthma, cystic fibrosis, aspirin sensitivity. We're going to go into some of these details as we move on. So first off is, how do we diagnose a patient with chronic sinusitis? What are the diagnostic criteria? So most of the consensus guidelines suggest you have to have 2 out of 4 symptoms for more than 12 weeks straight. And those 4 symptoms are nasal blockage, nasal drainage, facial pain and pressure, and loss of smell. So if you have any 2 of those symptoms for more than 3 months, then that certainly is suggestive of chronic sinusitis. Now, we'll talk later that to really prove it, you need to look in the nose and or have radiology to have an objective evidence, but certainly it's a symptom-based diagnosis. When you think about chronic sinusitis, from a phenotypic standpoint, we can separate it into 2 groups, those with and without polyps. When we talk about the non-polyp group, those are patients that you look in the nose and you don't see these grape-like protuberances. Now, they tend to look a little bit different from a symptom standpoint. Patients without polyps tend to complain more of facial pain and pressure and thick nasal drainage, whereas patients with polyps will sometimes complain more of nasal congestion and smell loss. And we're going to talk much more about the underlying endotypes, but in non-polyp patients tend to be more neutrophilic. Polyp patients tend to be more eosinophilic in nature. So what about prevalence? When it comes to nasal polyps specifically, the worldwide prevalence is somewhere between 1% and 4%. Studies in the United States are roughly about 4% of the population has this. When you think of chronic sinusitis overall, represents about 1/4, maybe up to 30 or 1/3 of the patients with chronic sinusitis. Interestingly, the average chronic sinus patient tends to be more female, slightly more than men, but in a polyp patient, there's slightly more men than women. And the average age is about 40, where most patients kind of falling into the 40 to 60 year age range, which is an interesting thing to think about, that, something happens later in life that results in development of nasal polyps. We talked a little bit about comorbidities, and there's sort of 2 big ones that we talk about. And one is asthma, and the other is allergic rhinitis. And these are important because they add to the overall symptom complex that patients have and their overall quality of life impairments. asthma is one specifically to mention. When we think about the unified airway hypothesis, the lining of the nose and the sinuses extends all the way down to the airway. And we know that the same pathophysiology, the same inflammatory profile that's going on in the upper airway is going on in the lower airway in patients with asthma. And poorly controlled sinus disease and polyps can result in poorly controlled asthma. So really quick, we're going to transition. I'm going to hand things off to Sanaz. She's going to talk to us about the patient perspective of somebody with nasal polyps.
Thank you, Dr. Soler. And as you guys know, the patient journey is really important for patient-centered care. So we're going to start off with a polling question. Which characterizes the typical patient journey from symptom onset to diagnosis? And the options are A, patients are typically immediately diagnosed by their primary care provider. Option B, patients are typically immediately diagnosed by a specialist, which can be referred by their PCP or self-referred. Option C is patients typically see several doctors, including specialists, over several years. Or option D, patients are typically diagnosed within several years because they're often not comfortable talking about symptoms. And while you answer that, we asked a similar question earlier today during a patient webinar. So from the patient perspective, we asked which characterizes your personal journey to diagnosis. And you'll notice that the vast majority of the respondents said that they saw several doctors, including primary care and specialists, before being diagnosed. And this really shows some of the frustration we've heard from a lot of patients. Oftentimes they're going from doctor to doctor, talking about their symptoms and talking about, trying to find the root cause until they're finally diagnosed. So we do hear about long journeys to diagnosis for nasal polyps. And jumping back to the question that we just asked you, it looks like the majority said C, patients typically see several doctors, including specialists, over several years. So this does align with what the patients have said to us as well. So understanding the patient journey, we participated in a qualitative study back in 2019, where we really tried to map out what the journey for patients looked like when dealing with nasal polyps. We supported a survey of 25 patients with nasal polyps and also did a physician survey of 20 physicians. This included interviews, and then we also had patients submit diaries. And the findings from these studies were separated into 4 key stages of the patient journey. So we looked at onset, diagnosis, disease management, and living with nasal polyps. So we'll go over some of these findings that were presented at a poster at ARS in 2019. So when we mapped out responses from these interviews, we saw that it really was a cycle. The patient journey started with symptom onset, but it was just kind of a cycle of suffering, treatment, and recurrence. And we saw that a lot of the patients were talking about negative impacts on daily life, on physical and emotional health. We saw a lot of patients talking about dissatisfaction with their care team or physician interactions because they felt like they were going back and forth to see different physicians to talk about their symptoms and treatment options. We also heard a lot about financial burden leading to discontinuation of care for some. So it does seem to be a little bit of a cycle, and this does lead to some frustration and challenges for a lot of patients that we heard from. Jumping to the next polling question, please let us know which characterizes the typical patient experience with treatment. So it could be option A, it was a breeze, we found the right medication the first time out. Option B, a little frustrating, but we found the right medication after a couple of trials. Option C, very frustrating, but we found the right approach eventually. Or option D, we still haven't found the right medication or approach and have been trying for ages. And while you guys answer that, we asked a similar question again of patients. We asked which statement characterizes your experience with treatment. And about 60% said they still haven't been able to find the right medication and they have been trying for a while. We also had 20% each respond that either it was a breeze and found the right medication the first time around, or that it was very frustrating, but eventually found the right approach. So as you can see, this does vary significantly from patient to patient. This really does highlight the need for shared decision making so that, the doctors are working with their patients to make sure that they're reaching the right care for them. And it looks like for this poll, many of you said very frustrating, but we found the right approach eventually. So there is a little bit of a disconnect here with what the physicians are saying versus what the patients told us earlier, which is a lot of patients feel that they still have not been able to find the right medication. So this does, highlight the need for more awareness and education and shared decision-making with the patients. Going into just a few of the high-level results from the poster that was presented at ARS. Again, those 4 categories, we started with onset. A lot of patients telling us about the different symptoms that they experienced. They talked about trying to find the right care team or physician to go to, oftentimes starting with the PCP and many times not knowing that they needed a specialist right away. To the second stage of diagnosis, we've heard a lot of patient stories about how reaching a diagnosis was difficult and how it took a number of years. So it led to some frustration and challenges in the diagnosis stage. Eventually going to the third stage in disease management. Again, this is a cycle. So it's, as you manage the disease, it seems that there's recurrence of symptoms, there's suffering that comes and goes. We've heard a lot of that from patients as well. We've heard a lot of patients in the disease management stage talk about bouncing between different treatments, kind of like a trial and error, and seeing recurrence of symptoms when they thought that they may have gone away. They've also talked about how surgery has been brought up as an option during the disease management stage. The next stage we laid out was living with nasal polyps. So of course, there's a lot of quality of life issues with nasal polyps, but many patients are learning to cope based on their symptoms, but they're also just kind of going through this recurring cycle of suffering. And with that, I will pass it over to Dr. Soler for utility scores.
Great. So I want to talk a little bit about the overall impacts on health that patients with chronic sinusitis with nasal polyps have. And, some of the audience may not be familiar with what a health state utility is, and it can be complicated, but just in brief, it's a patient's overall assessment of their state of health, like how good do they feel overall? And if you ask patients like this, you can get some interesting insights. So, these graphs are a little bit hard to understand, but the upper left corner here is basically graphing the overall health state with how they rate their symptoms from sinusitis. And what it shows is that a patient with chronic sinusitis, their overall health state is dominated by their sinus disease. It is what's predicting how they feel on a day-to-day basis. On the upper right here, you can see that there's really no correlation between the CT score and their health state or the endoscopy score in their health state. And that's an important point I just wanted to get across, that objective things like endoscopy scores or how bad a CT looks doesn't always predict how much impact there is on a patient's actual life, which is why we focus so much on patient-reported outcomes and really try to let patients dictate and guide the treatment decisions that we do. So how does nasal polyps or chronic sinusitis compare with other disease states? Well, that's what's nice about a utility score is you can compare across diseases. So here highlighted, and don't worry about the numbers here, but chronic sinusitis is highlighted in black here. And you can see it slots right in between Parkinson's, asthma, and end-stage renal disease with hemodialysis. So, patients with chronic sinusitis, their overall quality of life is significantly poor. Here's another study that did something very similar. This horizontal line here is the health state of somebody with chronic sinusitis. You can see it's way worse than somebody with seasonal allergies. In this study, way worse than just asthma. And really it's slotting in here with some pretty significant diseases like liver failure, heart disease, etc. So, with that in mind, let's talk a little bit about pathophysiology. I'm going to pass things over to Dr. Basso to talk about how polyps form in the first place.
Thanks, Zach. So our current concept of how nasal polyps form is I'll show you in the next few slides, a progression. The slide that you're seeing now shows a normal nasal mucosa and colonization with microbes. There's a mucus layer with various microbes, a mucosal barrier, which is a sinonasal epithelium, some submucous glands, and a few scattered inflammatory cells. That's the normal state. What we think happens is that there is a disruption of the barrier. And once that barrier is disrupted, one of the theories for barrier disruption is that there is an increased abundance or a decreased diversity of certain microbes. But there may be other factors that weigh into this. There may be viruses and pollutants and allergen proteases, et cetera, that break down this barrier. Once this barrier has been breached, the next thing you'll see is that the epithelium starts releasing inflammatory cytokines. And those inflammatory cytokines will then feed into both the innate and the adaptive immune system to promulgate a very robust immune response by recruiting and expanding a whole pool of inflammatory cells. Then you get exudation of fluid, tissue swelling, as well as the deposition of cross-linked fibrin, which is key to the remodeling. So what you finally see here is tissue remodeling. You see this invagination of the sinonasal epithelium. You see inflammatory cells that are entering into the polyp. You see the cross-linked fibrin, and you also see that the submucous glands have reduced in number. So we think this is how they form. Again, this could change in a few years when we get more information, but this is our current concept. What's even more complex is the type of inflammation that is available or which is interacting with the type of polyp that this patient may have. So for example, we're looking at endotypes. Endotypes are mechanistic types versus phenotypes is what you see. So there isn't always a correlation. In other words, not all patients with nasal polyps have a specific endotype. We know in the Western world that 85% of patients with nasal polyps have what's called type 2 inflammation. And that's really what's promulgated by cytokines IL-4, IL-5, and IL-13. That's also put forth by ILC2, which are innate lymphoid type 2 cells, and type 2 T helper cells. Now those interact to produce an eosinophilic milieu as well as a high release of cysteinoleukotrienes. When patients have type 2 inflammation in a nasal polyp, one thing we know is a few things will be forthcoming from that. One, that the disease severity is going to be greater in these patients, that their polyps will recur more quickly, and that their risk of developing asthma is going to be higher. Now don't forget, there are also type 1 and type 3 inflammation. Type 1 and type 3 are neutrophilic types of inflammation. There's more known about type 1, but in type 1 inflammation, gamma interferon is the main cytokine, whereas in type 3 inflammation, IL-17 is the main cytokine. What you need to know is that the old adage about CRS without nasal polyps being purely a type 1 and CRS with nasal polyps being purely a type 2 is really oversimplified. While there can be predominance of one type over another, there can be interplay between the two types. So certainly there's more that we need to understand about the endotyping. Let's talk a little bit about this important type 2 mediated inflammatory cascade in nasal polyps. So as you see up top, you have various factors like microbes and proteases that are breaking down the lining of the sinonasal epithelium. Once that barrier is broken, as we mentioned, epithelial cytokines, TSLP, IL-33, and IL-25 are being released. And then that is going to set forth both a stimulation of both the adaptive and the innate immune response. The innate immune response through the ILC2 cell and the adaptive immune response both through the dendritic cell, which then stimulates T and B cells to be active, and then also directly over to the mast cells. What's then going to happen is you're going to get a high abundance of cytokines, most of which are type 2 cytokines, which are going to be IL-4, IL-5, and IL-13. So IL-4 is responsible for the production of IgE antibody, which then feeds forward into that inflammatory cascade with release of mediators, and then stimulation again of the ILC2 cells, and a continued loop. IL-13, which is really important, not just in recruiting cells and mucus production, but it has a key effect in the cross-linking of fibrin, so that remodeling that we saw. And then IL-5 is a stimulator of propagation and proliferation of eosinophils. Put that all together and you have a very robust inflammatory cascade that becomes difficult to treat. There are a number of CRS with nasal polyp endotypes. And here's listed a few of them, the most common ones: allergic fungal rhinosinusitis, which is an IgE-mediated mold hypersensitivity; aspirin-exacerbated respiratory disease, or AERD, which is a triad of CRS with nasal polyps, asthma, and a respiratory sensitivity to aspirin and NSAIDs; central compartment atopic disease, which is usually an outgrowth of severe allergic rhinitis, which then causes swelling of the middle turbinate and the ethmoid sinus compartment. And then eosinophilic granulomatous polyangiitis, EGPA, or what used to be known as Church-Strauss syndrome, is a systemic vasculitis, which also includes nasal polyps and asthma, as well as systemic features that can involve virtually all organs of the body. Cystic fibrosis, as you know, is a inherited autosomal recessive condition where there are problems with the chloride channel, and mucus becomes very viscid, and these patients often form nasal polyps as part of their condition. And another rare condition is primary ciliary dyskinesia. These patients have difficulty with ciliary motility, and polyps can also be a manifestation of these endotypes. So it's important to keep in mind what are the major endotypes when you're looking at a patient with CRS with nasal polyps. Okay. Next, we're going to turn this back over to Zach to discuss diagnosis of nasal polyps.
All right, thanks, John. So we heard earlier, both from physicians, but also from patients, that they often bounce around and feel like it's years before the correct diagnosis is made. So how do we make this diagnosis? So it's a two-step process. And I mentioned earlier that the first step is a symptom-based criteria. So having 2 out of 4 symptoms for 12 weeks. So if you're a primary care physician or you're on the front lines, really it's focus on that patient who has this symptom complex that is really persisting for an unbroken period of time. That should really sort of prick up your ears to say, hey, this patient could have chronic sinusitis and they could have nasal polyps. So that's the first stage. But to really hone in on the diagnosis, you have to have objective evidence. And most of the time, I think the gold standard for this is using nasal endoscopy. This can use a rigid or a flexible fiber optic camera that allows you to put it through the nose into the sinonasal cavity and actually see the swelling, the visible polyps that are there. So this is the preferred methodology. If you look, there's a number of different polyp scoring systems. Most of the time they range from 0 to 8, so 0 to 4 on each side. And you can kind of look here and see what constitutes a grade 1 versus 2. I'm not sure that's that important, but it's probably something to at least reasonably appreciate, since most of the clinical trials that are looking at FDA-approved medications utilize these polyp scoring systems. Now, not everybody has the ability to have endoscopes in their office. They're expensive, they have to be cleaned, etc. So for a lot of physicians, it's going to be rhinoscopy. You're going to be looking in the nose with a speculum, maybe an otoscope. And I feel like the physical exam these days is something that's oftentimes sort of pushed to the side, but just encourage you to look in the nose. And yeah, you're not going to necessarily be able to see every polyp that's deep in there, but for patients with large polyps, you may see there and then be able to sort of hone in on this diagnosis. What about imaging? So CT scan is typically our imaging modality of choice. And the reason is that it gives a good assessment of the sinuses, their bony anatomy, whether they're opacified or not. It may not be able to tell you 100% whether there are polyps there or not, but it can certainly help you diagnose chronic sinusitis. Typically, it's not recommended to jump straight to this. Usually CT scans are reserved for somebody who you're considering surgery on, so they're a little bit later in the game. But certainly I have patients who I'm not sure, they have symptoms that seem like sinusitis, but they may not be. And I look in the nose and I don't really see anything definitively. And we say, hey, let's do a CT scan and be 100%. There's about 10% of the time where the endoscopy will be normal, yet they do have chronic sinus disease, and you'll miss it if you don't look further. MRI scan obviously would show you the sinuses as well. It's good for soft tissue detail. It's not something we typically do most of the time because it doesn't give us that good bony anatomy. But if you see unilateral polyps, that should certainly raise your alarm of that maybe this isn't just inflammation, maybe this is a neoplasm or something, and that might be a time where MRI makes sense. I wanted to touch on something called the Lund-Mackay radiologic CT score. Again, this is something you see a lot in research, not necessarily you're going to be utilizing this in clinical practice, but it's a scoring system where each sinus gets a score of 0 if it's clear, 2 if it's fully opacified, and a 1 if it's in between. And you add them all up and you get a score between 0 and 24. Again, just something to be aware of if you're reading the primary literature on this and you come across what a Lund-Mackay CT score is, you'll understand what that means. Wanted to touch on a couple of specific conditions. John just mentioned that there are subtypes of chronic sinusitis with polyps or endotypes, and allergic fungal sinusitis is one of those. And if you live in the South like I do, this is something that I see quite frequently. And it represents a type 1 hypersensitivity to mold. And in South Carolina, we have mold everywhere. I mean, you leave a piece of bread on the counter for too long, you're going to see mold on it. And these folks react to that significantly, forming nasal polyps. They have very characteristic CT findings, which I'll show you in a second. And one of the classic findings is at the time of surgery, when you open these sinuses, it's filled with this thick mucus. We call it allergic mucin. And the best way I can describe it is if you were a kid, you remember using rubber cement to glue things. If you leave that rubber cement out, it gets all gooey and sticky and thick. And that's what this allergic mucin looks like. This is a CT scan of a patient with allergic fungal sinusitis. And you can see, you have massive disease here eroding into the orbit, eroding through the skull base. You see these very classic hyperdense secretions filling the sinus. And I'll probably get a call once or twice a year from an ER where somebody's, gets a CT and they say, oh my gosh, you have a huge tumor, and the patients think they're going to die, and it's really allergic fungal sinusitis. Not to downplay its significance, but it's classic. Once you see it, you can diagnose it pretty straightforward. Next one to mention is just aspirin exacerbated respiratory disease, what used to be called aspirin triad disease or Samter's triad. And this is that patient with asthma, nasal polyps, and allergy or a reaction to aspirin or NSAIDs. And I feel like I see a lot of patients who have been struggling with polyps for years and had multiple surgeries and have asthma. And you look on their medical record and they're allergic to aspirin, but you say, hey, do you have this condition? And they say, I don't know what you're talking about. Nobody's just put it all together to say, hey, this is what you have. Sometimes patients, they'll say, well, I've never taken aspirin. I haven't taken it in many, many years. But there are clues to this. One of those is respiratory reactions to alcohol consumption. If you ask patients, hey, that patient who tells you, well, I haven't had an NSAID in 30 years. You say, well, what about alcohol? And they say, yeah, I don't do that either because I react to it. That again should sort of prick your attention that, hey, maybe this is AERD. And it's important to diagnose this because, as John mentioned, these patients have a phenotype that is more severe. Their polyps are much more likely to recur if they're not appropriately treated. And their underlying endotype probably does ask for specific treatments that may be different than other patients, including things like desensitization, which are options. And lastly, I wanted to touch on something that I think is less commonly understood, I think, is what we call central compartment atopic disease. And, there's this long debate that goes back to say, does allergy cause polyps? And we know, I said before that allergy is very common, like a lot of patients with polyps have allergy, but is it really driving the nasal polyp? Is it the cause of it? And at least for me, I don't think it is most of the time, but this central compartment atopic disease is a subset where I think it is true. These patients, you look in there and their middle turbinates and inferior turbinates are often degraded into polyps. Where in an average polyp patient, the middle turbinates and inferior turbinates look fine and the polyps are coming from the ethmoid. When you see that, it's indicative of this condition And it's often driven by inhalant allergy. And it's important because those are the patients where really aggressive allergy treatment, immunotherapy, et cetera, is probably going to be worth your time. This is a CT scan you can see. And if you just kind of look at the pattern here centrally, the middle turbinates are very inflamed, whereas the sinuses themselves are not actually that involved. Here's another CT very similar. Again, this, you can't just look at a CT and make this diagnosis, but you look inside the nose, you see the middle turbinates are degraded, you allergy test them and they're strongly positive. This may be a patient that fits this criteria. So now that we've talked about diagnosis, let's talk about management. What are the strategies to treat this? I'm going to hand this back over to Dr. Basso to take this on.
Thank you, Zach. Before we talk about specific modes of treatment, I think it's important that we all keep in mind that there are certain alarm symptoms that the clinician should be aware of. And when they encounter these patients need immediate referral for appropriate care. So these include, and here's the list, but they often include anything related to the orbit or the eye, displaced globe, double vision, periorbital edema, severe headaches, frontal swelling. Some patients you can actually see swelling above their eyebrows in the frontal sinus area, just visibly externally. Patients will present sometimes with sepsis or meningitis if there's breakthrough infection that goes into the central nervous system. Neurological signs. Unilateral symptoms, as Dr. Soler said, are always a red flag for potential neoplasms, things like inverted papillomas. Bleeding and crusting could be a clue that there's a problem that's more serious. And if a patient complains of really horrible smells, we call that cacosmia, and that's also a potential red flag for wanting to get that patient evaluated very quickly. We rely on sinus irrigations as a major treatment for managing nasal polyps. Irrigation does a few things. It removes mucus, it removes allergens, and it removes other inflammatory mediators. What we'd like to do is get retrograde flow into the sinuses. And of course, after a sinus surgery, this is ideal. So a well-done sinus surgery will allow for deposition of topical therapy, including sinus irrigations, which are often accompanied by using corticosteroids mixed in with them. We'll talk about that in a second. Well, the oldest treatment around is oral corticosteroids. And we know that they've been shown to reduce the size of polyps. And I remember when they were the only medical therapy available. And they are often the initial therapy in a non-operated patient. So if a patient comes in and they may have tried over-the-counter nasal steroid sprays, they're not doing as well, or they're still having problems, we often give them an initial trial of an oral corticosteroid. And if someone has been doing well for a while but has an occasional exacerbation, again, we may give them a short course of oral corticosteroids. But it's really unacceptable in this day and age with the other therapies that are available to treat with long-term use of oral corticosteroids. We all know from medical school that all the side effects associated with oral corticosteroids. We'll discuss those in a moment. So the cornerstone of management has become really intranasal steroids. Okay, and unfortunately, the aqueous nasal sprays that are currently available are typically very ineffective because they only hit the inferior turbinate. And so that really is not where the action is when it comes to nasal polyps. It's more for allergic rhinitis is where the action is on the inferior turbinate. So someone ingeniously invented this enhanced delivery system, which basically brings topical steroids deep into the nose and where polyps begin. So in a non-operated patient, it'll deliver medication right into the middle meatus, which is what's between the middle turbinate and the inferior turbinate. And if you have a patient who's had a full sinus surgery, we have this spray reaching up into the frontal recess. So again, this medication would be approved for patients who did not respond to intranasal corticosteroid sprays, but it is an FDA-approved treatment that we've had available for a few years now. And as you can see in this pictorial, the mechanism is such that it has a mouthpiece as well as a nasal tip that stents the nasal valve. And so when you place this in your mouth and you actually blow into it as you spray the bottle, as you pump the bottle, and the blowing into it closes off the soft palate. By doing that, you increase intranasal pressure, and you can see on the far right that the delivery posteriorly and superiorly is much greater than in the middle, which is the delivery of a aqueous nasal spray. Now, there were two studies that were performed, Navigate 1 and Navigate 2. These are phase 3 studies with a large number, almost 500 patients, middle-aged average, and they used two doses, 186 and 372 micrograms twice daily, or a placebo, for 16 weeks. These were patients that had really severe polyps. They had high SNOT-22 scores, which means that their quality of life for their nasal symptoms was quite high. Almost all of them used steroids, and most of them had sinus surgeries. And the patients were randomized to either getting the low dose twice daily, the high dose twice daily, or the placebo. But all of them had used the EDS delivery device. And what you can see here, both in quality of life, that's the SNOT-22 score, as well as the polyp grade, both doses showed significant improvement in both parameters. So this was quite significant and led to the FDA approval as fluticasone. What other vehicles do we use? As I mentioned earlier, we often like to use dilute solutions of steroids and saline mixed together. And when patients have had sinus surgery, these high volume irrigations will deposit even up into the frontal sinus cavity, which is where you're going to get the beginning of any polyp regrowth. Frontal and ethmoid sinuses are often the first place, and it's important that they get, but all the areas of mucosa that have been opened surgically, when properly done, a high volume irrigation will get delivery of medication to those areas. In Europe, but less commonly here, there are some patients who will have used concentrated solutions. They might put a budesonide respule directly into their nose. Oftentimes we have them laying in various positions to try to reach different sinuses. This can be uncomfortable, but there's some patients who actually prefer this mode of therapy. Okay, so finally, what are the role of antibiotics in CRS with nasal polyp management? Well, this is somewhat controversial. The literature is developing on this. There have been some recent studies that look good, but basically what they focus on are antibiotics that have both anti-inflammatory properties as well as the ability to reduce Staph aureus, which, as we showed earlier, is a potential aggravator, a colonizer that it releases toxins that actually stimulate inflammation. So doxycycline, over a period of 3 weeks, has been shown to significantly reduce polyp size and local inflammation. Again, this seems to occur in only a subset of patients. Again, it's also temporary. We also have some data showing that macrolide antibiotics, which have anti-inflammatory properties as well, and it's really for the anti-inflammatory properties, low-dose macrolide antibiotics used over a period of 4 to 6 months may be helpful in polyp cases where patients do not respond well to corticosteroids. In other words, those patients may not have type 2 inflammation, which is really what works, where steroids work the best in that type 2 inflammatory process. Some of these patients with CRS, remember, only 85% of them are dominated by type 2. That leaves 15% in the Western world. In Asia, there's actually a greater number of people who are not type 2. But in the low type 2 patients, this is where, or the type 1 patients, this is where you might get a response to macrolide antibiotics. So now I'm going to turn this back over to our surgeon, Dr. Soler, to discuss surgery.
All right, so let's start with another audience response question. So what do you explain about nasal polyp surgery to your patients? So this would be both for surgeons and non-surgeons. A, it takes the polyps out and recurrence risk is low. B, it's not a standalone treatment. C, it works, but the polyps can grow back in many cases. Or D, I rarely recommend surgery to patients. So while you're answering that, A somewhat similar question was asked to patients. Does surgery for nasal polyps work in all or most cases? And 78%, so the vast majority, said it usually works, but the polyps can grow back in many cases. A handful of patients says, yes, it's great. A handful said, no, it doesn't work, and nobody was really worried about it being dangerous. So, you know, this is an interesting thing. You know, what I think it jives with what I tell most of my patients, which is to say, hey, you know, if I'm offering you surgery, I do think surgery works, but not in and of itself. It also has to be combined with long-term medical management. Looks like the vast majority of physicians here said it works, but the polyps can grow back in many cases. So this agreement here between doctors and physicians. So let's talk a little bit more about surgery. So when would we consider surgery? So obviously patients have to have the diagnosis of chronic sinusitis and really have to have failed ongoing medical treatment. And we slotted in surgery into this talk on the management options because it fits in right around here where John left off. So typically patients are going to have tried oral steroids, tried topical steroids, maybe enhanced delivery systems. And despite all of that, they're continuing to have issues with their disease, both visible polyps, and then most importantly, that the patients themselves are bothered enough that they want to pursue surgery. You know, we mentioned before about a quality of life score, the SNOT 22 score, and I think most people have heard of this. It's just a nice way of quantifying the different symptoms involved and how bad it impacts a patient. And if you look at what actually impacts a patient and what makes them choose to have surgery, it's really their quality of life. It doesn't matter how big a polyp is or what their CT looks like, it's how much they're impacted. And if a patient has a very low score, no matter if they have polyps or not, they're not necessarily going to have surgery, where if their score is really significantly bad, then they're going to be begging to do some type of treatment. So what is endoscopic sinus surgery? Well, first, what it isn't, it's not just polypectomy. It's not just snatching out a few polyps. It isn't balloon dilation, or at least in I think most experts' opinion. And like I said, it's not a standalone cure. I think it's very rare that you're going to do a sinus surgery and nothing else, no other medical treatment, and somehow think that the polyps won't come back. What is it? It's removal of all the polyps, but perhaps more importantly, it's maximal opening of the sinuses, removing of all the partitions between the ethmoid. And we'll talk about why that's important in a second. Typically, we'll correct anatomic problems that are there if there's a bad septal deviation and large turbinates, because that's going to optimize delivery of medications. And like I said, its goal is really to improve the control of disease. So here's a picture. This is a sagittal CT scan. You can see this is a patient who doesn't have sinus disease, but you can see all these little ethmoid partitions. And this is what it would look like after a well-done surgery. All of those partitions would be removed. And what that does is it now allows you to deliver topical steroids, topical medications into the nose and sinuses and actually have that reach the tissues it needs to get to. Prior to surgery, it's really just getting into the nasal cavity. Even with enhanced delivery, it may get into the middle meatus, but it's certainly not getting deep within. And after surgery, it allows you to do that. And of course, rinses and things will allow the mucus to get out as well. So again, you know, when we see a patient after surgery who looks like this is typically a cavity of surgery plus medical management, that's going to be a happy patient. Here, you know, versus the pre-scan where this obviously is not a happy patient there. So I'm going to transition back to John to talk about, all right, what happens next? Like, what are the newer, more advanced medical treatments for nasal polyps?
Thank you, Zach. All right, so we want to talk about the new approved biologics. These are certainly the hot new guys on the street. They have been around for a while and have been approved for asthma and other allergic conditions, but only recently have they been approved for CRS with nasal polyps. So on your left, you see dupilumab, which is the IL-4 receptor alpha. And that, as you can see, is in common to both the IL-4 and IL-13 signaling system. And so it blocks the signaling of IL-4 and 13, which, as you know, are two key cytokines in the type 2 inflammatory pathway. So it's a big blocker of, a major blocker of that pathway. In addition, omalizumab on the right, that's also known as anti-IgE because it blocks free IgE. But its anti-inflammatory action is not just the blockage of free IgE. Next, you get reduction of cell-bound IgE. And then those high affinity receptors internalize. They reduce in number, and that basically stabilizes these inflammatory cells so that they don't reduce their mediators. And of course, that reduces allergic inflammation and the patient improves. So that's the true anti-inflammatory action of omalizumab. Now, dupilumab had two key studies that were phase 3 studies that gained its FDA approval. And there were over 700 patients that were adults that were entered into these studies. One was a 24-week called Liberty Sinus 24, and the Liberty Sinus 52 was the 52-week study. These are patients that had very high endoscopic scores in disease severity. They were symptomatic despite using steroids systemically, almost all of them. The majority had polyp surgery. Their SNOT-22 scores were quite high. And they were randomized to either receive dupilumab 300 milligrams or placebo every 2 weeks for 24 weeks in the Sinus 20 study, or in the Sinus 52 study, dupilumab every 2 weeks for 24 weeks, and then every 4 weeks for the remaining 28, or placebo. So now you can see the nasal polyp score results on the upper two graphs, and basically it's less than a reduction of a score of 2, not a linear scale, but that is a very significant reduction in the polyp. And although it didn't completely eliminate polyps on the average, there's a significant reduction. What is that the patient who is off treatment several weeks, which eventually returned to base, quite significant. As you see in the Sinus 52 study, the longer the patient was on it, there was continued improvement. A nasal congestion or obstruction, similar results here for both studies, and basically showing that there was a very significant reduction in nasal congestion scores as well as nasal polyp scores. The other key piece of information from these studies that was garnished was that in the placebo group, greater than 40% of these patients either ended up needing surgery or another surgery, or steroids, a rescue steroid burst, whereas only about 12% of patients in the treatment group needed one of either an additional surgery or steroids. Now, if you look at the two studies that were the phase 3 studies for omalizumab that gained them FDA approval, the reduction in the polyp score was a little less dramatic. It was about negative 1.25 for both polyp 1 and polyp 2 studies, which were basically two studies with the same design, very similar to the dupilumab design. Both were studied in patients who failed intranasal corticosteroid sprays. And then you can see that the nasal congestion scores also were significantly reduced, as were other symptoms like runny nose and postnasal drainage. I wanted to mention AERD, aspirin desensitization therapy. We alluded to it earlier. There have been numerous studies now in the literature. This is something that's been used for over 40 years. And the vast majority of studies recommend desensitizing patients who fall only into this subtype, which probably somewhere around 35% of all nasal polyp cases. Well, I should say 35% of nasal polyp cases of patients who have asthma. So of the patients who have adult onset nasal polyps and asthma, 35% of those will have AERD. And what it did was basically reduce polyp recurrence, nasal symptom scores, sense of smell improved, steroid use reduced, alcohol intolerance, which Zach mentioned earlier, also was reduced, is showing that there's a similar mechanism there, which really is related to mediator release. And then most importantly for the patient is that their quality of life scores improved dramatically, both on the SF-12 and the SNOT-22 questionnaires. So that's been shown to be effective in that subgroup of patients. And so if we put this all together, we did convene recently, there was a group of allergists, immunologists, and rhinologists who got together and tried to put together all the available therapies and what they think the best order would be for most patients, or at least some way of thinking about a pathway of treatment. And so, as we said, most patients will start with over-the-counter intranasal corticosteroid sprays. Oftentimes, that's not going to be enough. And early on, they'll get a short burst of oral corticosteroids. They'll get reassessed perhaps about 4 weeks later is about when you'd want to see when they're improving. If they have persistent symptoms, these are the patients where you want to take a step back and say, hey, you know, they recurred right after steroids. Maybe they have allergy as an underlying driver of the condition. Maybe they have AERD. We should do an aspirin challenge. Maybe we should do allergy testing. Maybe we should check their eosinophils and their peripheral blood. Maybe they have vasculitis, so we can check an ANCA, or maybe their total IgE is really high, and this is what's driving the polyps. And then we would transition over to patients getting the enhanced delivery system, or we would consider another burst of oral corticosteroids while we're doing this workup to see if we can get some information that would help with the diagnosis and the treatment, sort of what we call endotype specific therapy. Now, if patients fail that, we're going to escalate the treatment. So for the majority of patients who get escalated, they're going to end up needing sinus surgery. And so, as Zach mentioned, sinus surgery does not come in a solo form. It's not something that's done in a vacuum. It is done with postoperative management. And we mentioned the topical corticosteroid, the different methods by which they're delivered, and the delivery after surgery, of course, is much more effective. And then if a patient fails sinus surgery followed by topical corticosteroids, then we're going to consider that patient perhaps needs to have a multidisciplinary management. Maybe this is a patient where we may want to be thinking about biologics, especially if they have severe asthma. Maybe they need a revision surgery because they didn't have a complete surgery. Perhaps they have AERD and we want to consider aspirin desensitization. We have these steroid sinus implants that are sometimes useful for the first 3 months after surgery, particularly for certain areas that tend to grow polyps early to try to keep those areas open. That might be something that we could use. And again, maybe another burst of oral corticosteroids. But if they have persistent disease after that, and the evaluation of biologics, the agreement is that it takes about 6 months to see whether a biologic, or for that matter, for aspirin desensitization, to actually have an effect. But assuming that the patient still has persistent disease, then you're going to go back into the loop and consider an additional therapy and perhaps combinations of those therapies. Now, for a minority of patients who fail the first part of the algorithm, maybe they have a contraindication of surgery. Maybe they just, no matter what, do not want to have surgery. Perhaps someone in their family had a really bad experience and it's really hard to talk them out of it, or they may have other reasons for it. But for the patient who has poorly controlled asthma, despite standard therapy, or oral corticosteroid dependent asthma, biologics are going to be considered earlier. And the reason is that they've already been approved for these patients who have severe asthma. Of course, if they have severe asthma and CRS with nasal polyps, now that's sort of a patient that has potentially two disease states, which are probably actually one disease state that's affecting two parts of the airway that may respond to this therapy. And there may be a better sort of bang for the buck in that particular patient with their therapy. So if you take the paradigm of the mild CRS with nasal polyp patient, maybe they have small polyps, limited sinus inflammation, the central compartment disease that Zach described. They have low SNOT-22 scores. They're not really that severe. That patient comes in, they're probably going to get an oral steroid burst when they come into our office. We're going to put them on long-term topical steroids. And then we're going to evaluate and treat them to see if they have underlying comorbid conditions such as allergic rhinitis. I think most people would agree with that standard approach for the mild patient. I don't see a lot of mild patients in my office, but they may present in other places. So there's also was very good agreement amongst the experts for what to do with this severe patient. This is a patient we're basically going to use all the tools in our tool shed. This is a patient that has severe diffuse inflammation, remodeling, osteitis, inspissated secretion, they can't smell, high-grade polyps. Most of these patients will have comorbid, moderate to severe asthma. And the approach here is going to be pretty much a comprehensive one, and it needs to be coordinated. So that means surgery, complete surgery. And then that means followed by coordinated and combination medical therapy. And we mentioned these therapies as being oral and topical steroids, endotype-specific therapies such as aspirin desensitization, or perhaps immunotherapy for allergic fungal rhinosinusitis. T2 biologics are going to be a big player in these severe patients. There was some debate and I wouldn't say disagreement, but there was some debate between the surgeons and the allergists in terms of the middle of the road moderate patient. And this patient is, the majority of the patients we see fall into this category. And so here's where comorbidities, endotype, those things need to be taken into account. And so does the cost effectiveness, which Zach will talk about in coming up slides. Cost effectiveness is important in this situation. And what's also important is how does the patient feel about this, and what we call shared decision. How is it affecting their quality of life, and what are their inclinations after they've heard your recommendations. So next I'm going to hand this back over to Dr. Solar to discuss the economic impacts of the new biologics.
Great, thanks, John. So, a lot of times you'll read an article or you'll listen to a lecture and you say, okay, but in the real world, things cost money and there's all these different things that impact decision-making. So let's just briefly touch on that. And I'm just going to skip ahead to sort of costs of therapies. And so here's a list here, sticker price and what it really is, we can debate about that. But, obviously there's some sticker shock if you look at the cost of biologics of tens and tens of $thousands across the course of a year. Obviously, sinus surgery can have a high upfront cost, $4,000 listed here, but it can be much higher depending on where you're having surgery. Implants cost money, aspirin desensitization, protocols, and then patients have to pay for their medications as well, and there's high variability with those costs. So the one thing I wanted to mention is to always take this back to your individual patient and just kind of think about the perspectives of economics. And, one question I always ask is, who's paying for this particular medicine? I had a patient the other day who, she told me I don't even think she had gas money to get to the office. But I knew she needed a biologic. I said, man, there's no way this is going to happen. But sure enough, we actually got it approved. And even though she didn't have enough gas money to pay for that, she had this expensive medicine actually didn't cost her specifically money. So in her particular case, it really wasn't a significant issue. Now, obviously, we need to think about perspectives of, well, somebody's paying, right? Insurance, Medicare, society, or whatever. But each individual patient is going to have their own situation. I think it's important to think about time horizon. So what's important to somebody? Is it upfront costs? Do they have enough money upfront to pay the copay to have their surgery? Maybe they do, maybe they don't. What about long-term costs? I have patients who I say, hey, this is only $30 a month. And the moment that comes out of my mouth, I just sort of say, oh, because $30 a month to me is nothing, to them it's a huge thing. So we think about what is the time horizon we're interested in. And lastly, I think it's always important in these times to say who's getting paid. What are the incentives that might exist to your hospital? Perhaps you as a surgeon or you as a non-surgeon physician, what are your incentives to push a patient in a particular direction? Who's making the money off of this particular patient? And I think at the end of the day, to step back and say, all right, putting all that aside, what's most important for this patient? What's going to help them? So with that, I kind of want to bring things to a conclusion and just hit some highlights. So first, I think we learned that chronic sinusitis with polyps, particularly in the greater understanding, is an under-recognized condition. Unfortunately, patients may wait years before seeking care, and when they do, they often bounce around different doctors before they reach the right diagnosis. We talked a bit about comorbidities like asthma, allergies that influence somebody's overall quality of life. We talked about the high recurrence rate with treatments, including surgery, if you don't combine it with the right comprehensive care. We touched a little bit on new delivery systems, both for topical steroid sprays, steroid rinses, and we also talked about new medications, the biologics that target type 2 inflammatory pathways. So I think we are just on time. I think we probably have a couple minutes for questions. I'm going to hand things back over to Dr. Basso to see if there's any questions we can touch on in the last couple minutes.
Okay, I think we only have time for one question, and we'll have to go with the one that was most requested, and that is, how does dupilumab work on nasal polyps? So the answer is, and I think we answered this in one of the slides, but to review, dupilumab has a central role in blocking two key inflammatory cytokines, IL-4 and IL-13 from signaling. And IL-4, remember, produces IgE, and it also feeds the pathway going. IL-13 is responsible for laying down that meshwork, that cross-link fibrin. And so without that, there really is no structure to the polyp. So those are the two things. And of course, when you put all the anti-inflammatory effects of those two together, you really are reducing, with the exception of bringing the eosinophil number, which would need an anti-IL-5, you really are reducing quite a bit of what's going on in that polyp. And so that's pretty much the mechanism of how this works. And I think that's all we have time for questions, I believe. So be sure to watch the companion patient session, Taking Charge to Breathe Easier, Strategies to Address Nasal Polyps, now available on MedLive. And thank you, Dr. Soler and Ms. Eftekari, and thank you to our audience for great questions. I would like to also thank Optinose US Incorporated, Regeneron Pharmaceuticals, Sanofi Genzyme for their support of this educational activity. Please remember to complete the post-test at the end of the session to secure your CME credits. Please visit immunologylive.com to view today's session along with other sessions on demand. My name is Dr. John Basso. Thank you for joining us today.